Hello everybody, this is Dr. Nadeem. We are with Neelam Path Lectures, the Pursue series. As you are aware, all our lectures are available on YouTube. We also have a Telegram group. Please join the group, which is very helpful in accessing all lecture related information. We have a Google Drive where the PDF of all lectures are available. These are the disclaimers. We are with phase 3, which is recorded pathology lectures. And today we have Pursue 1S, which is renal cell tumor session 2. This is the WHO 5th edition 2022 oriented approach. To talk on this topic, we have Dr. Mitadru De Sarkar, who is an MBBS from JIPMER, MD from JIPMER. He's a consultant histopathologist and cytopathologist and overall quality in charge at Calcutta Heart Clinic and Hospital, Kolkata. Consultant histopathologist at Wizderm Pathlabs, a specialty dermatopathology lab. He's an ex-assistant professor at the Department of Pathology, SMV Medical College and Hospital. Also an ex-consultant pathologist at SRL Diagnostics, Fortis Hospital, Anandapur. Dr. De Sarkar has authored a book which is titled Brain Tumor Pathology for Postgraduate. This is available on Amazon. This is the link available here. This is the details of the book. It is also available on Kindle. So you can go and view the book on Amazon. It's a very good book. So with this, I would request Dr. Mitadru De Sarkar to start his lecture on session 2 of renal cell tumors, a 2022 WHO 5th edition oriented approach. Over to you, Dr. Mitadru De Sarkar. Thank you.
Hello, and welcome to this discussion on renal cell tumors. This is the second part of a two-series discussion based on the WHO 5th edition 2022. We have already talked about the big entities, that is the clear cell renal cell carcinoma, multilocular cystic renal neoplasm of the low malignant potential, renal papillary renal cell carcinoma, chromophore renal cell carcinoma, and the clear cell papillary renal cell tumor. So in this discussion, we shall be focusing mostly on collecting duct carcinomas, tubulocystic renal carcinomas, mucinous tubular and spindle cell carcinomas, along with a few of these molecularly defined renal cell carcinomas which have made their way into the new WHO classification. Now coming onto the first entity, that is the tubulocystic renal cell carcinoma. It's a very well localized T1 to T2 type of a presenting RCC, which is usually mostly incidentally found and indolent tumor and is seen in the age group of 30 to 74 years. The cut appearance is as if that of a bubble wrap which has been stretched on the surface of the tumor. So it's got a predominantly cystic appearance. And there are multiple cysts of varying sizes which are filled with clear fluid. You don't get solid areas, necrosis, or hemorrhage within this tumor. Histologically, you will just get multiple variably sized tubules and cysts of varying sizes, which are lined by cuboidal to hobnailed epithelium. And the cells will have prominent nucleoli. So by definition, they have prominent nucleoli, hence they are not really graded because nucleolar size is the basis by which we grade RCCs. And the cells have abundant eosinophilic cytoplasm. The stroma is usually fibrotic or desmoplastic. The immunohistochemical profile is that of the usual papillary RCC in the sense that the cells are positive for CK7 as well as MKR. A few cells can show expression for high molecular weight keratins. And unlike fumarate hydratase deficient RCCs, which can also have a tubulocystic presentation, these tumors retain the nuclear expression of fumarate hydratase. So in this particular case, as you see, there's a very well circumscribed tumor, which is clearly delineated from the perinephric fat, and which on a higher power appears to have a mostly tubulocystic morphology. So these tubules are of varying sizes and are lined by monolayered cuboidal cells. And these cuboidal cells have got prominent nucleoli. And the cells are cuboidal to hobnailed. So you can appreciate the hobnailing of the cells towards the luminal aspect and appreciate the large size of the nucleolus as well. Now, coming to the acquired cystic disease associated RCC, this is usually present in patients who have been on hemodialysis for a long period of time and are having end-stage renal disease. So on grossing, at the time of grossing, you see multiple cysts of varying sizes which are obliterating the architecture. Now, this kind of secondary cystic disease is expected in the case of an end-stage renal disease patient who has been on dialysis support for a long period of time. However, towards the left, you see one nodule, which is really not a cyst. It's more of a solid golden yellow colored nodule, which is pretty large compared to the other cysts that you see in the background. So this is the incidentally discovered acquired cystic disease associated RCC, which is developed in this case. And most of these cases will usually have low clinical stage and they have an indolent course. And sometimes, however, recurrences or distant mets have been known to occur. The cut surface is usually a yellowish tan, slightly golden yellow kind of an appearance. And on histology, sorry, you get tubules, papillae, as well as a tubulopapillary configuration. But characteristically, you get a microcystic architecture wherein you get these cribriform spaces which are punctuating the spaces between the cells, as well as forming lumina within the cytoplasm of the cells. The cells usually have conspicuous nucleoli, and an overall appearance is that of a sieve-like cribriform appearance. Another very important distinguishing feature of this particular type of renal cell carcinoma is the presence of brownish intratumoral oxalate crystals. Immunohistochemistry, so on immunohistochemistry, you get expression of MKR, but the cells are negative for expression of CK7. You also have expression of PAX8, CD10, and RCC marker antigen. Like in this particular case, towards the left, you see the tumor, and at a higher power view, you get this cribriform microcystic kind of an architecture, and you get this brownish deposits of extracellular kind of deposits, which are the oxalate crystals basically, which have been deposited in the background. So presence of oxalate crystals within the RCC component is an important diagnostic marker for this particular type of renal cell carcinoma. And here you see these cribriform spaces which are present just not between the cells, they're also present within the cytoplasm of the cells. Now coming to mucinous tubular and spindle cell carcinoma, this is an old entity which has not really changed even in this new WHO classification. Mostly the patients are asymptomatic and the renal mass is usually incidentally discovered of a T1 to T2 stage and confined to the kidney. They usually arise in the cortex as very well circumscribed lesions with a grayish brown tan yellow cut surface, and there is not you don't usually see invasion of the perinephric fat or the renal sinus fat. Very well demarcated tumors, but sometimes you can have tumors with high grade transformation where you can get invasion of the perinephric or the renal sinus fat. Usually there's a female predilection and there's a broad age range for presentation of this particular tumor. Histologically, you get a kind of a triphasic histology in the sense that you get a pale mucoid myxoid background. You get a spindle cell element which appears to be arranged in the form of short fascicles. And if you look closely, you will also see these tubular elements, that is these tubules, which can be sometimes elongated and aligned by cuboidal cells of a low nuclear grade, usually grade 1 to grade 2. But remember that it's not in every instance that you will get all the three components of this histology. So sometimes you could have a mucin poor and a tubular rich architecture, while sometimes you might get a predominance of the spindle cells. So it can have a heterogeneous kind of a morphology. Then the nuclei are of low grade, but sometimes you can get a high grade transformation where you have high grade nuclei, necrosis, mitosis, etc. And sometimes you can have a frank sarcometer transformation also within this case. Like in this case, you see these tubules of varying sizes which are closely coalescent. You see the pale myxoid background focally. So this is the mucinous bubbly background which you see in the background. And you have also this spindle cell element which appears to be growing in the form of short fascicles. And the nuclear grade, as I have already said, is low, grade 1 to grade 2. So in this case, you see a very well circumscribed renal tumor, which at a higher power, you can make out this pale mucoid background, as you see. And you also have the short intersecting fascicles of spindle cells over here. So you already have two of these components, and at a higher power view, if you were to look closely, you also have these tubular elements where my cursor is circling around. You have these tubular elements which are blending in with the myxoid background at places. And over here, you have the spindle cell element as well. So you get this spindle cell element, and as you can see, where the cursor is floating around, you get these stretched out elongated tubules which are lined by cuboidal cells. So this is the spindle cell element for you, short fascicles. The myxoid background can be well appreciated. And these are the tubular elements which are lined by the cuboidal cells with low-grade nuclear features. However, in this particular case, you might have a problem in the sense that the mucinous element as well as the spindle cell element both are poor. Both are less well represented in this particular example. So this is an example of a tubular element rich mucinous tubular spindle cell carcinoma. However, as you see, as is the nature of this tumor, it's a very well circumscribed tumor where it is well delineated from the adjacent renal parenchyma. You get these irregular ragged slit-like spaces of varying sizes which are seen in the background. And on close view, you see that these are elongated, small to elongated tubules along with a slight tubulopapillary architecture focally. Like over here, if you see, where the cursor is circling around, you have a bit of a tubulopapillary configuration as well. Now, this configuration can also be seen in the case of a papillary renal cell carcinoma, this tubular to tubulopapillary configuration. So, on a true-cut biopsy, a tubulopapillary architecture as this with a poor component of mucin as well as an indistinct spindle cell element could raise the differential diagnosis of a papillary RCC as well. So here you see the small tubules and the tubulopapillary architecture of the mucin poor mucinous tubular and spindle cell carcinoma. However, even if like here, if you look closely, you'll see that the background shows you this pale, slightly bubbly mucin at places like where my cursor is circling around. So that's an important diagnostic clue. And if you look closely, there will be areas between the tubules where you get these spindle cells, which seem to be growing in a slightly fascicular configuration, like over here. So you have the spindle cell element along with the tubular component. And if you look closely, you will also see the pale, bubbly mucin floating around here and there. Immunohistochemically, these cells have the same IHC profile as that of a papillary RCC, in the sense that they also express CK7 and MKR. So IHC will not really help you if you have got a mucin poor case of a mucinous tubular and spindle cell carcinoma, because when it comes to its main differential diagnosis, papillary RCC, both have got the same immunoprofile. Another new entity that has come up recently is the ALK rearranged renal cell carcinomas, which can sometimes have a mucinous background along with a spindle cell rich cell population. However, these elongated tubules that we have described over here usually are not well appreciable in the case of ALK rearranged renal cell carcinomas. And of course, immunohistochemistry will help because those tumors are positive for CK7 and negative for MKR and express positive ALK by immunohistochemistry. And you will confirm that by doing a break apart fish for ALK rearrangements. Special stains will help in the form of Alcian blue, where you can pick up the indistinct mucin on the H&E stain can be picked up by an Alcian blue stain, as you see on the image on the right. And as I have already said, CK7 and MKR are both positive in the case of mucinous tubular and spindle cell carcinomas. Now, this is a new entity which has been included in the latest WHO classification, that is the eosinophilic solid and cystic RCC. As the name suggests, this is a tumor which is predominantly cystic and also with a smaller solid component to it. These are usually incidentally discovered T1 to T2 stage tumors with a solid cystic appearance, and sometimes they are associated with tuberous sclerosis complex, and also sometimes with biallelic mutations in tuberous sclerosis 1 and tuberous sclerosis 2 genes. The cells, by definition, are polygonal, large, with voluminous eosinophilic cytoplasm with coarse basophilic cytoplasmic stipples. That's one important point. And sometimes you can also make out the presence of vacuoles within the cytoplasm of the cells, which could be either large or small, which can result in a slightly cleared appearance of the cytoplasm. Nuclei are usually round to oval, and pleomorphism is not well appreciable. And these large cells usually line the septae, because as I have said that it's a cystic solid tumor. So you have got the septae which line the cysts, and these cells which line the septae sometimes exhibit some amount of hobnailing, as you see over here. So these are the septae which line the cyst wall, and the cells lining them are large, polygonal, with abundant eosinophilic cytoplasm. Some of those cells appear to have multiple nuclei. So multi-nucleation is also another important feature which is present in some of these cells. If you look closely in the image D, you will see that these cells, although they are having eosinophilic cytoplasm and they're large, at some places the cytoplasm shows presence of clear vacuoles, resulting in a multi-vacuolated appearance. And within them, you also get this coarse purplish to kind of basophilic dots, resulting in a kind of a stippled appearance to the cytoplasm. And sometimes you will also have hyaline cytoplasmic globules, like you see in the image number E. In some cases, the cells are arranged in a nested configuration, as you see in the image C. Sometimes these vacuoles, as seen in the image F, they form large aggregates resulting in a distension of the cytoplasm, forming large vacuoles. And within these vacuoles, you will get this characteristic purplish to basophilic granules. So you see these small stippled granules within the cytoplasm, slightly purplish, slightly basophilic. This is an important diagnostic clue of this particular form of RCC. And as I have already said, multiple vacuoles can be present within the cytoplasm sometimes. Sometimes they can have nuclear features of PTC in the form of longitudinal nuclear groovings, nuclear inclusions, even samoma bodies. Multinucleation can be seen as seen in the inset. Within these multinucleated cells, you can sometimes get emperipolysis of the smaller tumor cells. And immunohistochemically, this has got an interesting immunoprofile because the cells are negative for CK7 and express CK20. Now, collecting duct carcinoma. This is a high-grade carcinoma, which, as the name suggests, because it arises from the collecting ducts, it will have a medullary component. So these arise from the medulla, but sometimes they grow to such large sizes that they extend into the cortex and even into the perinephric fat. But the important thing to keep in mind is that they will always have a medullary component, just like, say, a high-grade urothelial carcinoma of the pelvic LICL system or a renal medullary carcinoma. These overlap clinicopathologically with a few other types of RCC in the form of fumarate hydratase deficient RCC, papillary RCC, mucinous tubular spindle cell RCC with a high-grade transformation. These are highly aggressive tumors, and approximately 2/3 of the patients are dead within 2 years of diagnosis. They usually have a gray-white to firm and hemorrhagic necrotic appearance with very ill-demarcated borders, unlike the well-circumscribed pseudo-encapsulated border that you see in the case of clear cell RCC or in the case of papillary RCC. You don't have a circumscription over here. You have infiltration of the adjacent renal parenchyma. And the architecture is on the, when you see the slides, on the histology, you have a predominantly tubular kind of a configuration. So you have got tubules to tubulopapillary architecture with irregular infiltrating glands within a stroma, which is very, very desmoplastic and also inflamed. There is a lot of lymphocytic infiltration in the background, but sometimes, quite often, you will also get a prominent neutrophilic infiltration within the tumoral element. And the nuclear features are high grade. And sometimes you can get sarcomatoid differentiation and rhabdoid cells as well. Lymphovascular invasion and regional node involvement are also common. So as you see in the image on the left, you have got a high-grade adenocarcinoma kind of a morphology. You have this ill-formed tubules to trabeculae, which are seen to infiltrate through the stroma. And towards the right, you have a characteristic tubulopapillary architecture. So towards the right, cases like this could be actually misdiagnosed as a type 2 papillary RCC. Sometimes you will also get a cribriform architecture. This kind of architecture that you see on the left, this prominent cribriform architecture is also often seen in the case of a renal medullary carcinoma. And this stroma will show frequent presence of additional features like desmoplasia or inflammation. And in this particular case, as you see, there's a solid component to the top where you cannot see any glandular or a papillary differentiation. However, you see a lot of inflammatory element in the background. So whenever you have this kind of a solid architecture in a tumor which is predominantly located towards the region of the medulla, you will always also have to think of the possibility of a high-grade urothelial carcinoma which has infiltrated into the adjacent medulla. Now, in this particular case, where you can see the tumoral element is actually scattered throughout the entire slide. So you see a bulk of it towards the right-hand side, while it is extending even towards the left, infiltrating around the region of the included nerve, and also encroaching into the region of the renal sinus fat. So now you have these irregularly sized infiltrative glands of varying size, which are seen to infiltrate through the desmoplastic stroma, which is also inflamed, which shows a lot of chronic inflammation, the characteristic finding what you see in the case of a CDC. And these atypical infiltrative glands are seen to insinuate through the native glomeruli and the native tubules. As you can see, these tubules are definitely atypical, lined by pleomorphic cells with coarse chromatin, prominent nucleoli, and you also have a bit of a cribriform architecture to these tubular elements at places. So you have these atypical infiltrative tubular elements lined by cells with grade 3 nuclear features. You also see the appreciable amount of desmoplastic change in the background. along with the inflammation. You see the presence of necrosis within the tumoral element. This is another case of collecting duct carcinoma wherein you have a predominantly solid to a focally cribriform architecture. So you have this infiltrative nodule which is present within the tumor, and this adjacent parenchyma also shows some amount of inflammation. So if you see here, over here, you are mostly getting solid nests, but also you are getting very ill-formed glands and cribriform clusters of these atypical cells within an inflamed and desmoplastic stroma. So the cells are definitely having a high nuclear grade. You also have a lot of inflammatory element which is admixed along with the tumor. High nuclear grade features are seen. And towards the left, you have the cribriform architecture along with the presence of necrosis within this cribriform foci. So you see the presence of necrosis within this foci along with the cribriform architecture of high nuclear grade. Now coming to immunohistochemistry of collecting duct carcinoma, these will express cytokeratins, EMA, high molecular weight, as well as the low molecular weight keratins, vimentin and Paxate. Unlike the renal medullary carcinoma, which will be deficient in SMARCB1, that is the INI protein, and will express OCT3/4 in 50% of the cases. In these cases, the pattern is exactly opposite. You have a retained expression of INI, and these cells are negative for OCT3/4. Similarly, unlike a high-grade urothelial carcinoma, these cells will not express GATA3. They will not express P63. Unlike a high-grade papillary renal cell carcinoma, they will not express MKR. Now, in these images, actually, this is a little bit of an unusual presentation in this case. For example, over here, you see that the infiltrating element of the carcinoma is actually negative for EMA. Although, remember that most of the cases of collecting duct carcinoma will express EMA. Over here, towards the right, you have the infiltrating tumoral element, which shows nuclear expression of Paxate. Like I said, the renal medullary carcinoma, or rather what we call SMARCB1 deficient renal medullary carcinoma, is an important histological differential diagnosis. Unlike a renal medullary carcinoma, over here, INI1 will be expressed within the nuclei and OCT3/4 will not be expressed. Like I said, so there are two very important differential diagnoses of a collecting duct carcinoma. So depending upon the histology could have a solid appearance or an appearance wherein you have atypical infiltrative glands. In both the cases, solid or a glandular pattern urothelial carcinoma and a renal medullary carcinoma, that is the SMARCB1 deficient renal medullary carcinomas, are important differential diagnosis of collecting duct carcinomas. Like for example, in this particular case, this is actually a high-grade urothelial carcinoma of the upper urinary tract, which is mimicking a collecting duct carcinoma. You get CK7 positivity, vimentin negativity, as in C. So vimentin positivity is expected only in the case of a collecting duct carcinoma. You have nuclear Paxate expression. Now remember that Paxate does not automatically translate into a collecting duct carcinoma because quite a few of the upper urinary tract urothelial carcinomas can also express nuclear Paxate. P63 is positive within this, within these cells, which would be unusual in the case of a collecting duct carcinoma. INI1 expression is retained in these tumor cells, so a renal medullary carcinoma is not being considered. However, this particular case is from a bit of an old article. Those days, GATA3 was not being utilized. So in this day and era, you will probably need to add a GATA3 to your panel to establish the final diagnosis of a high-grade urothelial carcinoma. This is a case of a fumarate hydratase deficient renal cell carcinoma wherein the architecture is predominantly tubulopapillary. Remember that tubulopapillary architecture can also be seen in the case of a collecting duct carcinoma. However, collecting duct carcinomas have retained expression of fumarate hydratase. In this case, in the image E, you see that the fumarate hydratase expression is lost within the tumor cells, while the 2SC expression is upregulated within the tumor cells. So this FH negativity and positivity for 2SC immunohistochemistry is characteristic of a fumarate hydratase deficient renal cell carcinoma, which is another important differential diagnosis for a collecting duct carcinoma. Carbonic anhydrase 9 can be present in around 1/4 of the cases of fumarate hydratase deficient renal cell carcinoma, as in this case. This last case, which is a differential diagnosis of a collecting duct carcinoma again, is a unclassified RCC with a medullary phenotype. Now, what does this mean? This means that histologically as well as immunohistochemistry wise, this tumor mimics a renal medullary carcinoma. That is, they have a loss of INI expression along with a high nuclear grade and a characteristic presentation that of a renal medullary carcinoma, but the tumor that we call renal medullary carcinoma is characteristically associated with a sickle cell hemoglobinopathy. In these cases, although they look like renal medullary carcinomas, these carcinomas do not have a associated sickle cell hemoglobinopathy, so they are classified as unclassified RCCs with a medullary phenotype. So over here you have a very bulky, very infiltrative tumor obliterating the entire corticomedullary architecture. The architecture is predominantly solid with a lot of necrosis within the tumoral elements, and the cells are, and the atypical cells are eosinophilic polygonal cells with prominent nucleoli. CK7 shows a diffuse positive expression within these cells. Fumarate hydratase expression is retained, so you are not thinking of a fumarate hydratase deficient RCC in this case. INI1 shows a complete shows a complete lack of expression within these tumor cells. And on a FISH, you see that there is a loss of one SMARCB1, that is INI1 allele. So everything fits in place as that of a renal medullary carcinoma. The only thing is that in this particular case, you are not having a history of sickle cell hemoglobinopathy. So you will end with a terminology of unclassified RCC with a medullary phenotype. So these are the various differential diagnoses of a collecting duct carcinoma, as I've already said: high-grade urothelial carcinoma of the pelvic LICL system, fumarate hydratase deficient renal cell carcinoma, a SMARCB1 deficient renal medullary carcinoma, a metastatic adenocarcinoma. Obviously, because you are having a high-grade adenocarcinoma, you will need to exclude the possibility of a metastasis from some other source, but a metastatic tumor is usually bilateral. And rarely, if you have a collecting duct carcinoma with a papillary pattern, you can have a differential diagnosis of a papillary renal cell carcinoma, what we used to call papillary RCC of the type 2. Okay, but papillary RCCs are usually a very well circumscribed tumor with a pseudocapsule around them. Desmoplasia is usually not seen in the case of papillary renal cell carcinoma. Similarly, the inflammation that you see in the case of a CDC will usually not be seen in the case of a papillary RCC. And this papillae will usually contain foamy macrophages. They are usually positive for both CK7 and MKR and negative for expression of high molecular weight keratins. Coming to the translocation family of renal cell carcinomas. Now, priorly, these used to be called the MITF family of the translocation renal cell carcinomas, and now they have been split up into two entities which get two separate chapters in the new WHO classification. The first one is called a translocation renal cell carcinoma associated with the XP11 translocation, and in which the fusion partner could be the PRCC gene or the ASPCR1 gene. The other one of the translocational RCC is that with the translocation 611, wherein there is a rearrangement of the TFEB gene, resulting in most often fusion of the MELAT1 with the TFEB genes, but there are also other variant partners. The survival of the patients with the XP translocation is actually worse than that of the 611 translocation. They are almost equal as far as the prognosis goes with the aggressive forms of renal cell carcinomas like the clear cell renal cell carcinomas. TFEB arranged RCCs are usually indolent. However, they can metastasize, and they often metastasize late, as much as 20 to 30 years after the diagnosis. Now, this is a characteristic histology of the TFE3 rearranged RCC. So you have got a predominantly papillary to nested architecture wherein the cells have usually abundant voluminous clear cytoplasm. And another distinctive feature is the presence of some homobodies. Immunohistochemistry wise, this one important thing to keep in mind is that these translocational RCCs usually lack expression of cytokeratins and other epithelial markers like EMA. So they are usually consistently negative for expression of CKs and EMA, but they consistently express PAX8. Quite a few times you can get expression of melanocytic markers like melan A and HMB45 in this family of tumors. And as the name suggests, this is a TFE3 rearranged RCC, so you will have a strong nuclear TFE3 positivity on immunohistochemistry. However, keep in mind that this can be detected only with markers which are directed against the C-terminal portion of the TFE3. Another important thing is that this IHC is very, very finicky and will work only on a very well-fixed specimen. And because there is an issue of fixation heterogeneity and not all tumors will be equally fixed, IHC might not always give out good results. So in this particular case, actually, FISH, that is the break apart FISH for the TFE3 gene, is actually a better diagnostic procedure to choose compared to a TFE3 immunohistochemistry. Now, this is a case of a TFE3 rearranged RCC, wherein you can see that the cells are mostly arranged in the form of coalescent irregular tubules and nests. Overall, the cells have got a pale clear cytoplasmic appearance with a bit of cytoplasmic eosinophilic granularity here and there. But one distinctive feature is the presence of these samoma bodies in the background. So you have these cells with abundant clear cell-like morphology with abundant voluminous cytoplasm with grade 2 to grade 3 nuclear features. At places, you also have a little bit of this papillary architecture with the presence of this nice cores in the background, papillary cores. And when you do a TFE3 immunohistochemistry, you see that there's a diffuse positivity for TFE3 within the nucleus of the cells. There are also some other important diagnostic clues for this kind of TFE3 rearranged renal cell carcinomas. Like I've already said, they underexpress pancytokeratin and EMA. So you will get a negativity for both pancytokeratin as well as EMA, and also a negativity for carbonic anhydrase 9. So the first three images, A, B, and C, is the immunoprofile that you see in the case of a TFE3 rearranged RCC. While a conventional clear cell RCC will always show a diffuse expression of pancytokeratin and EMA, along with a strong pan-membranous positivity for carbonic anhydrase 9. So just a few simple markers could also help in differentiation of the TFE3 rearranged RCC from a clear cell kind of an RCC. As I've already said, cathepsin K is also an important IHC marker for these tumors. So you have a diffuse nuclear positivity for TFE3 along with cathepsin K expression, a pan-membranous expression of CD10. And as I've said, quite a few of these tumors will also show expression of HMB45 and melan A. Coming to the TFE-B rearranged family of RCCs, the architecture is predominantly nested. Within the nest, you get a population of cells with clear to slightly eosinophilic granular cytoplasm. But what is very unique about this particular type of RCC is the presence of a cluster of smaller cells with more scanty cytoplasm. And these cells appear to form clones being arranged around a highly eosinophilic core. So the presence of these smaller cells around these highly eosinophilic cores is what separates the TFE-B rearranged RCC from the TFE-3 family of RCC. Sometimes they can even have a high-grade nuclear morphology. And as I have already said, even this group of tumors will underexpress cytokeratins and EMA. Sometimes they can be totally negative for expression of cytokeratin and EMA, but they will also express PAX8, and they quite often express these melanoma markers like melan A and HMB45. Nuclear positivity for TFE-B is highly specific, but again, fixation plays an important part. So in a poorly fixed tumor, you will not get a proper TFE-B expression. So again, break apart FISH is a better diagnostic choice compared to immunohistochemistry in these tumors. Like in this case of a MELAT1 TFE-B rearranged renal cell carcinoma, you get these characteristic rosettes formed by the smaller cells, which are distributed around these hyaline cores. So that's an important diagnostic hallmark. Coming to the fumarate hydratase deficient renal cell carcinoma, the first thing that you would need to keep in mind about this group of renal cell carcinomas is that they are often very aggressive, often very high stage, and have a tendency to disseminate throughout the body, sometimes seeding the entire omentum and caking the peritoneum and spreading to distant sites like the liver. So as you see in this particular case, the image A shows that the tumor has gone through the perinephric fat, breached the gyrus fascia, and spread into the adjacent confines. This has also caked the omentum and seeded the mesentery, and has also given rise to large metastatic deposits in the liver. This is the group of tumors which are priorly in the past, they used to be called hereditary leiomyomatosis and renal cell carcinoma. So these were associated with also the presence of leiomyomas in skin and the uterus, which often showed a atypical feature. However, now this name of hereditary leiomyomatosis and RCC syndrome has been changed over to fumarate hydratase deficient renal cell carcinomas. These usually present at a very advanced stage with distant mets, and in the past they have been often misdiagnosed as unclassified high-grade renal cell carcinoma, or a type 2 papillary carcinoma, or even a collecting duct carcinoma. Now, although we say that most of these tumors have got a high-grade morphology, some of these tumors will also have a low-grade oncocytoid presentation, wherein you could even have a differential diagnosis of a chromophobe RCC or a succinate dehydrogenase deficient RCC. And nuclear atypia is actually not an important grading criterion for this tumor, because despite having prominent nucleoli along with nuclear atypia, some of these cases may have a favorable prognosis. So as I said, the architecture is often tubulopapillary or just a purely papillary pattern, but sometimes it could be a purely tubular or a tubulocystic architecture. Sorry, as you see in the case of the image C, or sometimes you could have large cystic spaces with the papillae protruding within these cystic spaces, giving rise to a tubulopapillary configuration, as you see in the image D. You could also have a solid to corded nested kind of an architecture sometimes. Just like in just as you see in the case of collecting duct carcinomas, you could sometimes have an infiltrating gland going within the desmoplastic stroma. You could also have, like as you see in the image C, here G, you see a cribriform pattern. So you could have a seed-like cribriform pattern with the small cystic spaces also within that. And characteristically, the cells have got a very prominent nucleolus with a prominent clearing around this particular nucleolus, giving rise to a perinucleolar halo. That is an important nuclear feature of this group of tumors. So these are the varied morphologies that you see in a case of fumarate hydratus deficient RCCs. Remember that the most characteristic one is the papillary configuration, but you could also get a tubulopapillary, tubulocystic, and cystic to papillary configuration along with a cribriform architecture to a solid pattern. So there are multiple types of presentation. However, irrespective of the histological architecture, the fact that binds all these tumors together is that there is a loss of expression of fumarate hydratis in the tumor cells, while there is a abnormal upregulation of the 2-succinylcysteine protein. So loss of fumarate hydratis, loss of FH, and upregulation of 2SC is an important diagnostic feature of the family of fumarate hydratis deficient renal cell carcinoma. Like in this particular case, if you see, there's a bit of a papillary configuration. So without any markers, you would probably call it a high grade, that is the type 2 papillary RCC. But when you do a fumarate hydratis, you see that the cells are lacking the expression of fumarate hydratis. And on the other hand, they have upregulated the expression of 2SC. So this is basically a fumarate hydratis deficient RCC. In this image, on the top from A to C, you have a case of fumarate hydratis deficient RCC, while below you have a conventional papillary RCC. As you see, both have got a papillary configuration. So without immunohistochemistry, you would call both as papillary RCC. However, in the first set of slides from A to C, you see that there is a loss of expression of fumarate hydratis. See that the control is actually the endothelial cells which are present within the course of this papillae. So there is a loss of fumarate hydratis expression and there is a gain of 2SC expression. So the first set from A to C is actually a fumarate hydratis deficient RCC, while from D to F, you have retained fumarate hydratis expression and a loss and a negativity for this 2SC, meaning that from D to F, the case that is seen over here is a conventional papillary RCC. This is another architecture that you see in the case of fumarate hydratis deficient RCC, where you don't get the papilla, but you get a mostly tubulocystic kind of a architecture. So this within these tubules and the cysts, you see that this lining is by cells which have got a hobnail configuration with a very prominent nucleolus with a perinucleolar halo seen in some of these cells. So when you do a fumarate hydratis immunohistochemistry, you will see that the cells are diffusely negative. They lack the expression of fumarate hydratis, unlike the endothelial cells which are seen within the adjacent stroma. Now coming to succinate dehydrogenase deficient renal cell carcinoma, this is again usually a low-grade kind of renal cell carcinoma and usually asymptomatic and an incidental finding. Such patients usually present with a history of a germline mutation in one of the 4 SDH, that is the succinate dehydrogenase genes, and they can also have other tumors in the form of pheochromocytoma, paraganglioma, GISTs, as well as the presence of pituitary adenomas. Now there are 4 genes, as I've said, A, B, C, D, but the most characteristic one which is usually mutated is the succinate dehydrogenase B gene, but A and C can also be mutated. The importance of the succinate dehydrogenase protein is that it's a key respiratory enzyme present in the Krebs cycle and in the electron transport chain. So if you have a deficiency of this particular protein, what happens is that the net effect is that of hypoxia, resulting in the accumulation of oncometabolites, resulting in tumorigenesis. Most of these cases will have a low-grade morphology and have a favorable prognosis, although around 10 to 15% of these cases will have a metastasis on a long-term follow-up. Usually they are very well circumscribed with a tan brown to red cut surface. Usually they are solid, as you see in the image on B, but sometimes a minor cystic change can also be appreciated within these tumors. And in as many as 1/3 of these tumors, multifocal or bilateral tumors can be found on long-term follow-up. Now, histologically, if you see, these tumors mostly tend to mimic the chromophobe RCC in the sense that these cells are usually pale to slightly flocculent eosinophilic kind of a cytoplasm. So this pale, bubbly to eosinophilic cytoplasm can be sometimes appreciable in the case of a chromophobe RCC as well. On top of that, some of these cells will show the characteristic inclusions of eosinophilic or pale flocculent eosinophilic deposits. So that's an important diagnostic clue. And within these tumor cells, you will get small microcysts which contain pale eosinophilic fluid. Immunohistochemistry-wise, SDHB, that is the succinate dehydrogenase B protein, is lost. So if you do an IHC for SDHB, you will see that the tumor cells have lost the expression of succinate dehydrogenase B, while the expression will be retained in the adjacent normal endothelial cells. We shall see a couple of images of the pattern of expression or the pattern of the loss of expression of SDHB that you see in these tumors. Remember that although these cells are mostly low grade, you can have higher grade transformation, especially if the cases are associated with a succinate dehydrogenase A type of mutation. Those will have a higher nuclear grade along with necrosis. And unlike chromophobe RCCs, they are usually negative for the expression of CD117. They are also frequently negative for cytokeratins, including CK7. That's an important thing to keep in mind. And fumarate hydratase expression, unlike the fumarate hydratase deficient RCC, is consistently preserved in these tumors. So over here, if you see, I've got a very well demarcated tumor that you see separated from the adjacent parenchyma, which is composed of polygonal, clear to slightly eosinophilic cytoplasm containing cells, which have got a pale, slightly flocculent cytoplasm within them. So if you see, you have got these larger polygonal cells which have got clear to slightly flocculent eosinophilic cytoplasm, and a few of them have got these dense cytoplasmic eosinophilic inclusions. So you see this flocculent nature to the cytoplasm. This is one of the reasons why you could confuse them with a chromophobe RCC sometimes, although the nuclear features of chromophobe RCC are not seen in this case. You don't have those resinoid nuclei or the perinuclear halo. Now, I was talking about the succinate dehydrogenase B expression. So you have a loss of succinate dehydrogenase B expression in these tumor cells. As you can see, the pattern of SDHB could vary from absolutely absent to a slight granular pattern, but even that would be treated as negative. What is the control? The control are your background endothelial cells, which will show a characteristic coarse granular positivity within the cytoplasm. So with this kind of expression in the background endothelial cells, when you compare the cells of the adjacent tumor, you will find that there is an absence of expression of the succinate dehydrogenase B protein. Now coming to this new family, this is an interesting family. This is an interesting genetically defined family of RCCs in the latest WHO classification. These are called ELOC gene mutated RCCs. Now, if you have to remember this entity as a snapshot, remember that these look either like the clear cell RCC or the papillary RCC. The only difference is that they appear to have a very thick fibromuscular bands which appear to be running through the tumor, dissecting the tumoral component into small nodules. So you have got an overall nodular configuration with thick fibromuscular bands within a tumor which could mimic a clear cell RCC or a papillary RCC. On immunohistochemistry, the cells are consistently positive for CK7, carbonic anhydrase 9, and CD10. As you see, there is a diffuse CK7 expression in this particular case. Now, in this case, this is a case of a ELOC gene mutated RCC. So you see this very prominent thick fibromuscular bands which are running through the parenchyma. And overall, if you see, otherwise in the background, the tumor appears to be like a conventional RCC. That is a conventional clear cell RCC. Like the only thing that is separating this particular type of RCC is this prominent thick muscular bands. So you get these fibromuscular bands which are dissecting through this tumor, which is otherwise a clear cell RCC like morphology. So you have these prominent fibromuscular bands. Like I said, this could look like a clear cell RCC, or even like a papillary RCC. So towards the top, you have got a clear cell RCC-like appearance with the prominent fibromuscular bands, while lower down, in another case, you have got a papillary RCC-like morphology. Carbonic anhydrase 9, like I said, is diffusely positive in a completely membranous fashion, whereas you can have a positivity for CK7, which is often diffuse, but sometimes can also be patchy, as we see in the lower image. High molecular weight keratins are negative or very focal, unlike a clear cell papillary renal cell tumor, which could be sometimes a differential diagnosis for this group of tumors. Coming to SMARC-B1 deficient renal medullary carcinoma. Now, this is a very important carcinoma to keep in mind because this has got a very characteristic association with a sickle cell hemoglobinopathy. So many of these patients will be asymptomatic sickle cell disease carriers. So that's an important thing to keep in mind. So definitionally, this group of tumors of SMARC-B1 deficient renal medullary carcinoma will have a history of a hemoglobinopathy, which is often a sickle cell trait, but could sometimes also be a sickle cell disease. And the age group is wide, starting from the childhood to the 7th decade of life, and often seen in the case of African patients. The characteristic definitional feature is a deficiency of the SMARC-B1 gene-associated protein, that is the SMARC-B1 protein. This protein is also variably known as INI1, BAF47, or SNF5. Now, these tumors are diffusely positive. They usually look like a high-grade adenocarcinoma on histology, and they're diffusely positive for broad-spectrum keratins, EMA, Paxet, and Vimentin. And as far as the expression of low molecular weight and the high molecular weight keratins go, they're variably positive. P53 expression can sometimes be seen. A very important immunohistochemical diagnostic feature of this group of tumors is that around half of these cases will show nuclear expression of OCT3/4. That is the germ cell tumor markers. Now, and also given the fact that quite a few of these tumors will have a morphology which mimics yolk sac tumor, a positivity for OCT3/4 along with that characteristic yolk sac-like cribriform microcystic architecture, especially if the patient has got widespread involvement of the retroperitoneal nodes, could lead to a DD dilemma of a metastatic germ cell tumor. So that's an important thing to keep in mind. And sometimes, as I've already said before, a few of these cases could look exactly like a SMARC-B1 deficient renal medullary carcinoma with a high-grade adenocarcinoma showing a loss of expression of INI1, but those cases will not have a history of a hemoglobinopathy. So some of those tumors are actually called an unclassified renal cell carcinoma with a medullary phenotype and not a SMARC-B1 deficient renal medullary carcinoma. As the name suggests, I said that it's mostly confined to the region of the medulla, but oftentimes, because these tumors are very large, they will tend to jump out from the medulla and go and infiltrate into the adjacent cortex and even go into the perinephric fat. Now, this type of presentation of a large, bulky, high-grade tumor which has got a significant medullary component is not a feature of a SMARC-B1 deficient renal medullary carcinoma alone. You could also get it in the case of a collecting duct carcinoma or a high-grade urothelial carcinoma of the pelvic LICL system. Like I said, the architecture is mostly a reticular microcystic kind of an architecture, which can mimic that of a yolk sac tumor. You could also have pure glands or a solid kind of an appearance. Now, this cribriform microcystic appearance and adenoid cystic-like overall microcystic configuration is often seen in the case of renal medullary carcinoma, and a tumoral infiltrate of inflammatory cells, that is neutrophils, is also a very frequent finding. So over here, you have the characteristic cribriform pattern, which is seen with cells having a high nuclear grade, at least grade 3 nuclear features are seen. And like I said, sometimes you can have a pattern of infiltrating tubules, just as you see in the case of a collecting duct carcinoma. Now, I've already said that these tumors are usually seen in the patient of a sickle cell hemoglobinopathy. So that's a very important diagnostic clue. You have to look around within the blood vessels in the background, and you will see sickled RBCs within the blood vessels as well as in the stroma adjacent to these blood vessels, and that's an important diagnostic clue as well. And if you have a INI1 on immunohistochemistry, you will see that the tumor cells are completely devoid of INI1, and you will have to compare it with the background inflammatory cells basically. So basically all the background normal cells will show retained expression of INI1, while the tumoral element will be negative for INI1 expression. And as I said, 50% of these cases will also show positivity for OCT3/4. Now this is got the characteristic reticular yolk sac-like tumor infiltrating pattern. And in the second image, you have got a cribriform pattern. In the third, you have got a predominantly solid sheet-like architecture with a little bit of rhabdoid morphology to the cells. So in a very young patient, sometimes even a rhabdoid tumor of the kidney could be a differential diagnosis for this particular tumor. And sometimes you can have just an infiltrating tubules within a desmoplastic stroma. So that's an important diagnostic feature sometimes, which could actually mimic a collecting duct carcinoma. Like you have got a solid high-grade high-grade kind of a presentation with extensive necrosis, and a kind of a rhabdoid presentation is seen here with very prominent nucleolus. You also have a cribriform sieve-like pattern, and in the last image, that is in D, you have got an appearance which mimics almost the usual reticular pattern that you see in the case of a yolk sac tumor. Sometimes you can have tubulopapillary architecture as well, or just a plain papillary configuration. The presence of sickled RBCs is an important diagnostic clue for these tumors. So the SMARCB1 family, that is the SMARCB1 deficient renal medullary carcinoma, can actually have a heterogeneous kind of a clinical, kind of a histological presentation, ranging from the cribriform microcystic appearance, as you see on the left, to a tubuloglandular morphology, to an extensively solid morphology which mimics high-grade urothelial carcinoma. You could have a diverse range of histological presentations. Like say, for example, in this virtual case, here you see there's this infiltrating tubular elements which form cribriform nests as well as papillary clusters at places, and these appear to insinuate through the normal glomeruli which are seen in the background, infiltrating through the normal tubular and the glomerular elements. These atypical glands are forming cribriform clusters at places. Another important thing to keep in mind is that sometimes these cells will have a mucinous element to them. So you see this mucoid element also, which is present in the background within the lumen of these tubules. And these tubules are lined by cells which are atypical. If you look at the background, you will see that there are these extravasated cells, quite a few of which look like sickled RBCs. So that's an important diagnostic clue. You are also seeing the presence of necrosis within the tumor. And over here, you are having these cribriform tubules forming a maze work of atypical cells, which have obviously got high-grade nuclear features. And look at the presence of the slightly mucinous matrix in the background of the tubules. Now, I said IHC, you have got two important markers. One is INI1. So if you compare these tumor cells with the background cellular element, especially the background renal tubules and the spindle cells in the background, you'll see that those elements have got the retained expression of INI1, while your tumor cells are lacking INI1 expression. And as I said, 50% of these cases will show a weak to moderate positivity, sometimes even strong positivity for OCT34. So you get expression of OCT34 in this particular case. So the overall morphology and the IHC favors a diagnosis of a SMARCB1 deficient renal medullary carcinoma. So these are the various markers which can be expected. OCT34, variable positivity, PAX8, S100 positivity, while there is a loss of expression of INI1 in this particular tumor. So there are the various differential diagnoses of the SMARCB1 deficient renal medullary carcinoma, starting from the high-grade urothelial carcinoma of the pelvic LACL system, which will definitely show GATA3 expression along with P63 with OCT34 negativity, and collecting duct carcinoma. Collecting duct carcinoma usually happens in an older age group compared to the renal medullary carcinoma. There is no association with the sickle cell hemoglobinopathy, and these are usually positive for high molecular weight keratins, which is not seen in the cases of renal medullary carcinoma. Now, remember that there are many other diverse cancer subtypes of renal cell carcinoma which have a secondary SMARCB1 deficiency. For example, fumarate hydratase deficient RCC or collecting duct carcinomas could have a secondary component of SMARCB1 loss. So if you have a tumor which fits characteristically into the definition of a collecting duct carcinoma or a fumarate hydratase deficient RCC, even if you have a SMARCB1, that is INI1 loss, do not call it a do not call it a renal medullary carcinoma. Rather, call it that specific renal cell carcinoma subtype with a secondary SMARCB1 deficiency. Sometimes, as I have already said, you could have a carcinoma which looks almost like a renal medullary carcinoma, both by histology as well as by immunohistochemistry, but there is an absence of a hemoglobinopathy. So in those cases, they are usually called an unclassified RCC with a medullary phenotype. And this last family, this last category of tumors is actually not really a morphological differential diagnosis of a renal medullary carcinoma, but I have brought this particular tumor into this group because this is another family of renal cell carcinomas which is seen in patients with sickle cell hemoglobinopathy. So keep that in mind. When you have a patient with sickle cell hemoglobinopathy, you could have a SMARC-B1 deficient renal medullary carcinoma, or you might get a vinculin ALK fusion associated renal cell carcinomas. However, those are usually small tumors which are usually organ confined, unlike a renal medullary carcinoma, and they show a strong ALK expression. And usually they have got prominent cytoplasmic vacuoles along with a polygonal and a spindle cell population. This brings me to the last entity of this discussion, that is the ALK rearranged family of renal cell carcinoma. So as I've already said, these are usually present in the patients of sickle cell hemoglobinopathies and can involve both children and adults, usually small and organ confined. They've got a solid to solid cystic appearance, and they have got a characteristic location, usually in the medullary location, and they have chronic inflammation at the periphery. They're usually composed of polygonal cells with abundant eosinophilic cytoplasm, often with striking vacuoles within the cytoplasm, and there is also a secondary spindle cell component. And because they are present in the patient of sickle cell hemoglobinopathies, you will get sickle cell RBCs even over here, but here the RBCs are usually seen in the background interstitium rather than in the vessels. The partner could be various other genes other than vinculin. So vinculin is the #1 gene which is rearranged with ALK, but you could also have rearrangements with TPM3, EML4, HOOK1, etc. Those kind of variant translocations could actually have a more heterogeneous presentation in the form of much more prominent vacuolization or very, very prominent mucoid background, a prominent cubiform architecture, etc. Some of these cases might even mimic a mucinous tubular and spindle cell carcinoma. These tumors are very well circumscribed, as I have shown in this case, tan white to tan pink in appearance, homogeneous and solid, and show an expansile growth. As I have said, the background has got usually a bubbly mucoid kind of an appearance. The cells often have voluminous cytoplasm with the presence of mucin even within the cytoplasm of the cells. And you will also have a smaller spindle cell element in these cases. Immunohistochemistry wise, as I already said, okay, by the way, you have abundant mucin, so that can be picked up with an Alcian blue stain. And IHC wise, they have got a characteristic profile in the sense they usually diffusely express CK7 but are negative for MKR, and they have a strong positivity for ALK within the cytoplasm, usually with a bit of an exacerbation towards the region of the membrane. So as I have already said, they are usually composed of cells with polygonal cells with presence of the prominent vacuoles within the cell. And they have also got a spindle cell element. And as you can see in the background, you also get this sickled RBCs, which is a sign of the hemoglobinopathy that these patients have in the background. Here you have a kind of a very circumscribed tumor with a prominent tubulocystic to a papillary configuration. Observe the pale mucoid myxoid matrix which is seen in the background. Sometimes you can also have a solid sheet-like architecture. And within these solid sheets, if you look closely, you will see that this mucin has also got into the cytoplasm of the cells, so that quite a few of these cells have a signet ring kind of an appearance. And ALK immunostaining is helpful in these cases. You could also sometimes have a papillary morphology, but the background would again be characteristically mucoid in such cases. ALK immunostaining is seen to be positive in these neoplastic cells. As I've already said, the immunohistochemistry profile shows a diffuse expression of CK7 while there is no MKR expression. CD10 will show you a focal patchy positivity here and there, while there is a nuclear expression of PAX2 and PAX8. Sometimes the architecture could be predominantly solid and the nuclear grade might be slightly higher, and the background RBCs would show sickling. So in such cases, a renal medullary carcinoma might be sometimes suspected, but if you do an INI1 IHC, you will see that the INI1 expression is retained. So this is against the diagnosis of a SMARC-B1 deficient renal medullary carcinoma. So this is a ALK rearranged RCC. And of course, at the end of the day, if you want to conclusively establish that particular diagnosis, that is an ALK rearranged RCC, you will have to do a break apart fish. So if you see this is the normal pattern, while the two while the two genes which have got separated are actually identified in the form of these orange and green signals which have been split apart. So these are the new entities which are included in the latest WHO 2022 classification. Some nomenclatures have changed, some new genetic entities have been defined. You will have to know about all that. So for example, you have to know that papillary RCC is no longer subclassified into type 1 and type 2 category. You will have to know that the clear cell papillary renal cell carcinoma is not now called a carcinoma, it's called a clear cell papillary renal cell tumor. TFE3 and TFE-B rearranged and altered RCCs have now got individual chapters of their own. The entity which was priorly called hereditary leiomyomatosis associated RCC is now called fumarate hydratase deficient RCC. Medullary carcinoma, renal medullary carcinoma has got the name changed over to, as I said, SMARC-B1 or INI1 deficient renal medullary carcinoma. You've got a new entity called eosinophilic solid and cystic renal cell carcinoma. You've got the family of ALK rearranged renal cell carcinomas. You have got ELOC mutated RCCs. And you have got these upcoming emerging entities, which we have already discussed in the section of the chromophobe RCCs, that is the low-grade oncocytic tumor and the eosinophilic vacuolated tumor, which are important differential diagnosis for oncocytic tumors like oncocytomas. You also have an emerging family of tumors of oncocytic renal neoplasms of low malignant potential. Thank you.